brainchild of our immediate past president, Dr. Ganaka Senaratne. We have been doing over last 1 year. Now, today also we are going to talk about a very important topic. This is actually for improve the knowledge and awareness of our budding physicians, budding internists. So without much ado, I would like to invite our president, Dr. Kumuduni Jayasinghe, to address the forum. Over to you, Dr. Kumuduni.
Thank you, Dr. Premali. Good evening, everyone. It's my pleasure to welcome everyone, all my colleagues, our senior registrars, and other doctors to this SLSIM Senior Registrar Forum. And I would like to extend a special welcome to our speaker today, Professor Arosha Dissanayake, who actually kindly accepted our invitation and spending his valuable time sharing his expertise on the topics, ethics at the bedside. I think he's the best person to talk on this. He not only talks about ethics, but also practices good ethical principles. We always respect and value his humanity. I must thank Dr. Priyamali, who's actually passionately leading the Senior Registrar Forum throughout, and for choosing today's topic and the best speaker for the topic. And we have conducted many Senior Registrar Forum, as Dr. Priyamali said, and would like to thank Dr. Ganaka Senaratne for establishing this forum to help the future internists to become more competent clinicians in the future. So while thanking all senior registrars and other doctors for joining, I invite you to have a great witness a great lecture. Thank you.
Thank you, Dr. Kumuduni. So I have selected the most suitable person for this topic, and very good human being, great clinician, is none other than Professor Arosha Dissanayake, our immediate past president of Ceylon College of Physicians and Professor in Medicine, University of Ruhuna. So he doesn't need much introduction. I would like to invite him to talk on ethics at the bedside. Over to you, Dr. Arosha. Yes, unmute your phone.
Okay, I hope you can hear me.
Can hear,
all
yes.
right, you can hear me.
Can
right.
hear.
Okay, thank you, Dr. Kumuduni Jayasinghe, President SLSIM, Dr. Ganaka Senaratne, immediate past president of SLSIM, and Dr. Priyamali, who from the SLSIM, my long-standing colleague from the CCP and the SLSIM both, Dr. Priyamali, who is coordinating this very important training program for us registrars, which I think involves training them to both become excellent consultants as well as work very well during their overseas training. I'm humbled by this invitation from the SLSIM to have been invited to speak on this very important topic. And my mandate from Dr. Priyamali was to make sure that I speak both about passing exams as well as clinical practice in the ward. And I will try to do that. Ethics and communication skills for exams and clinical practice. Okay. Sorry. Okay. Right now, looking at this, give me a second. I'm just trying to remove this. Okay. Now, ethics and communication skills are tested at every exam in your career. In the MBBS, many of you would have been tested in this. It may be slightly different in different universities, but in Ruhuna, where I teach, we have a OSCE station where we test communication skills, and that actually carries 2 marks out of 100. That's a lot of marks. In the sense, I think that amounts to about 10 correct to true false MCQs. So that's a lot of marks. Then, of course, when you go for the MD exam, I've ignored the MD entry exam, but the MD proper part 2 or the MD exam, we have a communication skills scenario where it's a observed patient interaction for which you will get marks as well as examiner will question. Then, of course, in the Viva, there is a separate ethics station. Now, I'm actually covering the MD also because I think there might be registrars also in the audience so that they will also get an idea about what is in store. Now, in the Viva, there is a separate ethics station, but in that ethics station, there is no patient involved. So what you are asked will be some kind of a philosophical analysis of an ethical dilemma. You'll have to analyze different aspects of an ethical dilemma and talk about it. So there's no patient, but it's an examiner interaction. Now, again, these two components will carry about 12 marks, I think, in the MD, which is again a lot of marks, It's about, it might be about getting three short cases or something like that, something to that effect. Then, of course, many of you who are senior registrars now and even registrars or even junior doctors will one day want to sit this exam called the MRCP, which is the specialist qualifying examination in the UK. The MRCP has a theory and a practical exam, and the practical exam is called PACES. And at this moment of time, in what's called the station 4, there are 5 stations. There is one 20-minute communication skills and ethics. They put both together. The MD, it's communication, but there might be some ethics things as well, but there's a separate ethics discussion. But the PACES, it's clear, it's a combination, maybe very often both together, communication skills and ethics station, which is over 20 minutes. Now, as you all may already know, that the PACES structure is changing. There's something called PACES 2023. From 2023, the structure will change. Instead of this, there will be 2 10-minute communication skills stations. And here it will be an observed interaction between the patient and the candidate, but examiners will not be questioning. And I think these two will be one based on ethics, ethical dilemma, and another pure communication. I think that's how it will be, but none of us know because we still not had training for the PACES 2023, but that is a very likely scenario. So what I'm trying to show is that there is no escape in terms of exams from communication skills and ethics. It will be tested at everything. Why is it tested at every exam? Because it is critically important. Right, so now we've looked at why we need to learn this from an exam point of view. Let's look at some other aspects of this. Right, I'll first spend some time looking at communication skills at exams. Communication skills, what may be tested? The first thing about passing an exam is to have an idea as to what are things that are usually tested. So this is, I made a list of a few things. There may be other things which I have forgotten to add. By all means, develop on this list. This is a good working list. One is, of course, you may be requested to speak to a patient to obtain consent for some procedure, maybe an angiogram, maybe exercise ECG, maybe even something simple like a lumbar puncture. But anything it could be, or maybe undergoing some complex, procedure like a thoracoscopic procedure, something like that. They can throw and obtaining a consent. What you must remember is in communication skills, it is not pure communication which is tested. Very often a knowledge component also comes in. There's no escape from that also. So if you are expected to explain a procedure, you have to have some understanding of what is going to happen in the procedure. If you're going to get consent for a, shall we say, thoracoscopy or a bronchoscopy, you have to have you may not need to know how to do a thoracoscopy or a bronchoscopy, but you need to have an idea about what is going to happen. Then only you can obtain valid consent. The second is, of course, mostly in undergraduate exams, we get people to explain the use of a device. It can be something simple like an insulin pen. how to use that, where to store that, etc. So that is another aspect which is tested. Then, of course, one of the very commonly asked ones is breaking bad news. Breaking bad news is for examiner, easy for examiners, because examiners don't need to be very creative, and they need not be very creative to come up with a breaking bad news scenario. So that's the easiest scenario that examiners can make, and that so it appears quite frequently in examinations. It may not be some very serious illness, but it could be some complex, long-lasting illness as well. Then, of course, discussing a DNA CPR decision. Do not attempt cardiopulmonary resuscitation decision. That is a complex discussion, but that can be asked. You must remember that early days we used to call these DNA decisions. We used to call these DNR decisions. Do not resuscitate. But what we're trying to say, resuscitation means a lot of things: IV fluids, food, antibiotics, etc. So decisions we're talking here are purely with regard to CPR. Are we going to give CPR to a patient who goes into cardiorespiratory arrest? So that's a DNA CPR decision, and that's slightly different from a DNR decision. Nowadays, DNR decisions are not taken, but DNA CPR decisions are taken. Then, of course, another scenario which examiners often think of is to have a problem. Somebody comes into the clinic with a very high blood sugar. You've given appropriate medicine, and he has this problem. Or you might come across a patient who has not taken COVID vaccination. It's a problem. And the patient's now got a respiratory tract infection. So there is a problem, and you're expected to solve it. Solve it in the sense what you are expected to do is to explore the problem, identify why this has happened, or identify the underlying cause, and then, of course, find a solution to overcome the problem. So that is also one thing which is tested at exams. Then, of course, another thing which is coming up quite a lot is explaining a complex illness. It's very difficult to explain illnesses, what they mean to people who are non-medical. That really tests you. I mean, just think about explaining what SLE is to somebody who is not a medical person. It can be very, very tricky, very, very difficult. So explaining complex decisions to patients, or explaining even bronchiectasis, things like bronchiectasis, or maybe take something like interstitial lung disease, how difficult it will be to explain. So explaining a complex decision, explaining prognosis of that illness, etc. Those are also some others. There's another concept called explaining uncertainty, which we hardly do in this country, but can be tested at something like the PACES. I once did a lecture on this, I think it was at the CCP a couple of years ago, where, very often in the ward, we don't know what the diagnosis is. We have only some vague idea what might be wrong, but what exactly is causing the current complicated situation, we don't know. And we are expected to explain to patients and thereby relations that we are uncertain about what is wrong, and that we are dealing with what we have, what little knowledge we possess, and we are going forward. So it's a difficult conversation, because it's much easier if you know exactly what the diagnosis is and what's wrong, even if you can't help it. But explaining uncertainty takes a lot of training and a lot of skill. Another one which you may be expected to do is to admit a mistake and apologize for a mistake. This again, we hardly ever give this in the MD, simply because within the Sri Lankan socio-cultural setup, very often if you admit a mistake and explain and apologize, mistake, it can have terrible consequences, such as having your photograph pasted all over social media, and maybe a YouTuber doing an entire program on you. So people are very hesitant. But nonetheless, that's an important aspect to think about, and that certainly happens in the UK, and that certainly will be tested at the PACES exam. So that is called the duty of candor to a patient. CANDOUR. Candor is your duty to speak the truth and admit the truth, your truthfulness, and being very candid and open about where we've gone. So these are the kind of scenarios that you're likely to be tested in an exam. Just to very briefly read the list: obtaining consent, explaining the use of a device, breaking bad news, discussing a DNA CPR decision, exploring a problem to find underlying cause and find a solution, explaining a complex illness, explaining uncertainty, and admitting a mistake and apologizing. Right, okay. Right, if indeed you get in a communication process in an exam, I've crystallized it into 7 steps. I think if you follow this for any scenario, if you roughly follow these 7 steps, that may get you reasonably good marks. Because at the communication skills testing station, the examiner will have a marking grid, and these are roughly the areas that they will award marks for. Now, first thing is, of course, introduction and setting. Setting is where you will sit with the patient, a place where the patient or the relation is comfortable to speak to you, which is free from disturbances, etc. Of course, that will not be happening in an exam, but that will be happening in a real life communication skills scenario. Then, of course, in terms of introduction, it would be important to say what your name is, and then say what your status is in the ward, and then ask the person in front of you name and confirm, is it the patient? If it's the patient, with the name maybe, but if it's a relative, to find exactly who he is of the relation of the patient. Now, again, culturally we are not used to introducing to people with our names, but in a country like UK, it is expected that you say who you are. I am Dr. Disarnayak. I am the consultant. That is, I think, in our society, people value your status or your job more than who you really are. I think that's the reason for that. But nonetheless, we need to get used to, because now when you train yourself, don't train yourself for the MBBS or the MD specifically, but train yourself for all exams and the ward, whichever country that you work in, Sri Lanka or overseas. So introduce yourself by name, say who you are, ask the patient what the name is, and confirm that it's a patient, or if it's a relative, then ensure that you confirm that this is so and so. The second step is outline the objective of the meeting and obtaining consent for the discussion. Now, you must tell the person, or, I'm so and so, I would like to discuss with you this morning about this particular aspect of your illness. Are you happy for me to do so? It might be, say, if it's a breaking bad news, it might be a pathology report that you have to talk about. Or maybe if it's obtaining a consent, you tell the person, I would like to speak to you about the test that we have planned for you, tell you what is going to happen at the test and test. Are you happy to speak now? So have some kind of outline about what is going to happen, because it is quite possible that, maybe if it's in the ward, your consultant may have already been to the patient and explained everything. And, you sitting down and the patient will say, no, the consultant came and told me what is going to happen. So to clear all doubts, just the ramu or the outline of what is going to happen now and obtain permission. That's step 2. Third thing, at exams, it is always looked for. And third thing is, of course, it is brilliant practice in the ward also to find out what the patient already knows. Now, I will mix this with some singular because that's what we usually use in the ward. So you tell the patient, "Man kamathi katha karanna, mata hungak udaw wenwa දැනගත්තොත් ඔබතුමා හරි ඔබතුමිය හරි දැනට මේ අසනීපය ගැන මොකක්ද දන්නේ කියලා දැනට කියලා තියෙන්නේ මොකක්ද කියලා, you know, what has the patient already been told, so that you know you can build up on that knowledge. Then of course fourth step is the one that will carry the highest number of marks. And again, remember these 7 steps, you will not have equal marks. Obviously for introduction, you won't have the same marks that you will get for explaining matters. But explaining might have more marks, maybe 40% of the marks or something. But what you explain, maybe it's obtaining consent, maybe it's explaining a complex illness, maybe explaining uncertainty, maybe consenting for a procedure, maybe a breaking bad news, maybe DNA, CPR decision, whatever it is, you need to match the health literacy of the patient. Now, that again is a place where you can actually ask the patient at this stage, you know, what you already know. May I also know, you know, now what kind of job you are doing? So very often the job will indicate what their literacy is. And if they say they are not doing an employment or self-employed, you could always ask them, may I know to what level you have been educated? So that you know, you are aware of the health literacy of the patient. Of course, you might feel that, you know, health literacy is low even in some very educated people, but keep things simple. And then of course you must use non-technical language. Now, at this point, it is very important because we have a tendency to use very medical jargon, and that will be looked upon as being a shortcoming by the examiner who is marking. I will tell you a little story here. I mean, I tell a lot of stories when I teach people. When I went for my PACES exam, that was a long time ago, I had to speak to a son of a patient who was having, I think, a subarachnoid hemorrhage, and then who was not recovering very well. And somewhere in my discussion, I mentioned that the patient will be sent to the speech and language therapist. To me, that looked fairly simple. And immediately after the conversation was over, the examiner challenged me and said, well, you used a very, very strong technical term. You spoke about speech and language therapist. Do you think the patient's son will know who that is? And, you know, etc. So he found fault with me, and then I immediately accepted, because I had learned this very well, the communication skills in the PACES, and I didn't use a single complex word, but that moment I had slipped. So I immediately said, you know, I was very mindful about that. I was very careful not to use, but that was a mistake. I'm sorry about it. If I were doing it again, I would not use that term. So the other thing to learn is, if at any time an examiner challenges you, don't challenge the examiner back. It is always safe to kind of, you know, admit your mistake. Even if you feel that it may not be a major mistake, just admit your mistake and say, I'm sorry about it, but, you know, next time I do it, I'll do it differently. You know, then the conversation finishes. There's nothing that they can do. If you say, next time I do this, so that's, again, remember that line. If you ever challenge them, just say, I'm sorry, yes, that was a mistake, but next time I do, it won't happen. So that the examiner cannot penalize you thereafter. And then, of course, simple vocabulary. Never use complex English words. Those who have worked in England will tell you that patients often don't know what urine is. And, you know, people talk about a waterworks system, etc., though it looks quite funny to us, because the registrars who come for the exam, you know, I'm sure Premali has also done, you know, both of us have examined candidates in England, English candidates at the PACES as well. We are both examined in England as well. But even in England, all the Suddha candidates, they will use extremely simple words to explain to their patients. And if we use medical terminology, that's not going to look good. Or any big English words like, you know, fever subsided. The fevers come down, they don't subside. Nobody knows what subside means. Clear the language has to be. Audible. You know, we can't, I mean, Sri Lankans are generally very polite people. We are soft-spoken people, but it is very important in a communication to be audible. And because audibility gives an impression of confidence. If somebody is not audible, examiner thinks that you're lacking in confidence. And also you need to have this quality of being friendly with the patient, that you're not some robot who is standing in front of the patient and speaking in robotic language, but somebody who is friendly with the patient. Friendly means, you know, that that inspires confidence in the patient, in you, and that amounts to what's called an empathic communication. Empathic communication. And there is this concept of chunking and checking. Chunking and checking is, if you're going to explain something very long to patient, don't keep on speaking on and on and on, but it is worthwhile once in a way to stop. Maybe after some time you stop and ask, I'm explaining something long. So can you tell me whether you understood everything I told you so far? Is there anything you want me to clarify? So when you feel you're talking too much, stop and make sure that the patient, so chunking is you're breaking it up, and checking is whether the patient has understood. Now, checking doesn't mean asking the patient to repeat what you have been telling them. That can be very intimidating to a patient. In an exam, that can be disastrous. So don't ask people to repeat what you have said, but you just clarify from them, did you understand what I said? Is there anything else that I need to tell you? Right? Okay. Then, of course, so that's step 4, which takes a lot of marks. So I want you all to think about this. All these aspects in your communication. It is not just conveying some facts to the patient, but there's a lot around the facts. How you convey is what will determine how you get marks. Then step 5 is, once you finish speaking about that, stop and ask, is there any clarity? Do you need anything clarified about what I told you? Anything any clarification about what was already discussed. You must finish that. So finish that, and thereafter, as step 6, you can ask, is there any other concern that you'd like to discuss with me at all? Is there anything else which is worrying? Now, this is what is traditionally known in communication things as icing the patient, or ice means ideas, concerns, and expectations. It's very difficult to kind of break it up and ask, but you could always ask, what are your worries or concerns? What do you want from us? What is your expectation from us? We'll try to do whatever we can, kind of thing. So icing bit comes at step 6, and out of the icing bits, the most important is any other conversation. Now, concerns. Now, Dr. Kumuduni and Dr. Premali, myself, we all examine at the MD as well, this communication, and the MRCP as well. So from an examiner perspective, we teach. Now, very often we have not real patients, but surrogates. So we teach the surrogates to have about 2 concerns. So once you finish, unless you ask about any other concerns, they won't tell you. And then the examiners will mark you down saying that you didn't ask for other concerns and you missed those concerns. Those concerns may at times be even absurd. More like once I remember we said for the MRCP PACES, somebody who's got knee swelling due to an osteoarthritis. But when you ask the patient's worry was, patient's sister has had a DVT in the past, and patient was worried that the patient was also having a serious DVT illness. Now, it sounds really absurd to us because here we have some knee joint swelling. But this important thing is you never dismiss a patient's concerns. That is something you must remember. You will always acknowledge the patient's concern. Acknowledge is, yes, now that you tell me that, I understand that you're worried about. That is acknowledging the concern. But may I tell you that, this is something completely different. This has nothing to do with the DVT. So don't worry, you'll be fine. Or if by any chance your communication skills is somebody whose blood sugar is high because the patient is not taking metformin because somebody is told metformin causes kidney failure, you don't tell the patient, no, that is a wrong belief. No, you don't dismiss patient's concerns. But you acknowledge. What you say is, yes, I do understand that there is a story which is doing rounds that metformin causes kidney failure. But what I want to tell you is metformin has been used for about 50 years now. There is a lot of research doctors have done in this country and overseas, and none of the research has shown that these kidneys are affected. So that is not a correct belief, though many people have it. So that's how. Now, acknowledging a concern doesn't mean accepting what the patient believes, a wrong belief. Now, you don't go and say, yes, kidney failure is caused by metformin, but still take metformin. That's a wrong belief. It's not accepting, but acknowledging, because patients have a right to believe what they want, even wrong things. All of us believe in religions, and who knows, these religions may be right, these religions may be wrong. We don't know. So, but we have a perfect right to believe in a religion, right? So it's our belief and it is important to us. So no one should laugh at our beliefs. Just the same way, patients have a right to believe anything. So you will listen to their belief, acknowledge their concern, and then explain the real situation. So that's the icing or any other concerns. And finally, step 7 will be to conclude. A conclusion, obviously, we say thank you. But what is important is to create a follow-up opportunity to reflect on the conversation and ask anything more. So you tell the patient, right, okay, now I've told a lot of things to you, and you know, all of these things may be having you worried. It's okay, you go home, think about this, and I'll be in the ward tomorrow morning. You are free to come and speak to me tomorrow morning in the ward. Then we will discuss further. So before you say thank you, you create an opportunity, create a window for patient to clarify any other doubts that they may have. I mean, you don't say silly things like, you know, I'll give you my telephone number, call me any time of the day, you know, because we expect doctors to be realistic. I mean, nobody gives the telephone number and say, you know, you call me anytime you want. We don't do that. But what we do is, in a more professional way, we will create an opportunity for them to come and meet us in the ward or clinic or wherever. So I want you all to remember these 7 steps. Now, you might be aware of something called the spikes model in Breaking Bad News. If you look at the spikes, I mean, it follows a similar pattern, but my problem with spikes is it has a step called empathy. You know, empathy is not a step, it's empathy is an overarching thing which covers all these things. So I think this is a tried and tested method, 7 steps, which will be introducing yourself and the patient, outlining the objectives of obtaining consent, finding out what the patient already knows, explain what the problem is, make sure that inquire whether there are any other matter, you know, whether everything that you've said is clear. Then 6th step is icing the patient or any other concerns. And then, of course, a good, strong conclusion where a patient and opportunity is created for the patient. So these are the 7 steps. Now, I spoke previously about all the things which can be asked in a communication skills thing. And then, of course, for any of these things, it is the same 7 steps. Only step 4 changes from 1 to 1. Whether it's using a device or breaking bad, you introduce yourself, set the outline, ask what the patient already know. Then comes the change as to, you know, how things change with each one. Then, of course, you know, clarifying what you have said, any other concerns, and strong conclusion that is common to everything. So this 7-step structure is common to every communication skill, and only number 4 changes from what you are asked. I hope I've made myself clear. Premali, am I being heard all right?
Yes, yes. Yeah.
Okay, right. Okay, and then you must tell me if I'm at any time, if I'm going overtime also, okay?
Yeah, and they are also, anyone want to ask a question from you, they can unmute themselves and ask.
I'm very happy to answer anybody. Can I, or shall I finish the ethics part also and then ask them?
No, that's, yeah, you can continue.
Yeah, that's fine.
Yeah, once you see to have questions, just let them know. Thank you.
Right. Okay, ethics is my pet hobby. I got interested in medical ethics a long time ago. I first attended a course in 2003 as a registrar, arranged by Professor Atula Sumatipala and Professor Sisira Siribardhan at that time. I'm very grateful to them for kindling this interest in ethics for me. And then, of course, it took, you know, as a senior registrar back in 2005, I made a presentation at the Young Physicians Forum at the CCP on ethics at the bedside, talking about clinical ethics. And actually that I won the Vijayarama Prize for the Young Physicians Forum back in 2005. So it has been something very dear to me, and a message which I've been trying to carry for the past maybe about 20 years. But I first got really interested in 2003. So it has been about 20 years. I've been working on this for about 20 years. So it's a pleasure. Thank you again for inviting me to talk about my very special area of interest in medicine, as well as being able to share with you. Now, ethics, if you look at it, is a branch of philosophy. Ethics is not medicine, ethics is philosophy, but philosophy which deals with morality. Now, morality is the right and the wrong of our actions. So morality is the right and the wrong, and then ethics is that branch of philosophy. Philosophy has many branches, but one branch of philosophy is ethics, and it deals with morality. Now, medical ethics refers to the dilemmas. Ethics always works in a context. Whenever there is a problem, there is no free-flowing ethics. It's always contextual. Dilemmas related to the duties that we have towards patients and others and our colleagues, etc., and outcomes in medical practice. Duties, and also when we carry out our duties, what the outcomes will be. Now, medical ethics roughly has 3 areas. Now, why people have all gone away from ethics is, just about every lecture that you hear in ethics is to do with research ethics. And they can be quite boring. I myself have done research ethics lectures, and they can be quite boring. I come close to falling asleep when I do research ethics lectures. And then, of course, many clinicians are not full-time researchers. They have only a passing interest in research. And, so unfortunately, too much talk on research ethics has driven people away from medical ethics. But our real passion is clinical ethics. There is a massive area in ethics called clinical ethics, and we'll speak about some of those today. Then, of course, there are professional ethics, which is to do with the etiquette or how you conduct yourself as a doctor within the professional community. So I'm not going to spend too much time on that, but let's look at clinical ethics, which is really our heart, and then spend time on research and a little bit on professional as well. Now, if you look at the General Medical Council, people are really struggling to find the difference between professionalism, ethics, and good medical practice. Good medical practice is probably the best term that we have to have for how we should be in the wards. Ethics is a part of good medical practice, but good medical practice will have other things as well. For example, having clear handwriting is part of good medical practice. Actually, if you look at the GMC, one of the things is clear handwriting, good medical practice. That's not ethics. So good medical practice is an umbrella term. It carries a lot of things, and ethics is one of them. So a beautiful document is the GMC thing on good medical practice. I suggest that you all have a look at that. Ek copy kali poddak tanin aragana copy kalla. There is the Sri Lanka Medical Council good medical practice. That's not a very sound document. That needs to be changed as soon as possible. Right, now I'm going to spend a few minutes talking about what classical ethical theories are. You might wonder why are we talking about this, but you will realize why I'm talking about it. I'll explain it very simply. Ethics, long before medical ethics came into being, people are talking about ethics for the past so many centuries. There are 2 major schools of ethical theories: deontology and utilitarianism. Very simply, deontology is your duty. We have a code which says, no, this is right and this is wrong. Deontology is our duty, and it says you do the correct. You do the correct thing always. Do the correct thing. You do the right thing. And then, of course, you have a human being in front of you, your patient, and you do the correct thing towards the patient. Utilitarianism is to say you must not look at the action, whether you are doing the correct thing or wrong thing, but you must look at the outcome. Utilitarian means world has so many billion people. What is right is what brings about the maximum amount of happiness to the maximum number of people. Very simple. So it says don't look at the act, but look at the outcome. So deontology looks at the act. It doesn't look at the outcome. Utilitarianism looks at the outcome and not at the act. Now, deontology is, for instance, a crude example is If someone was to come to Premali and say, I want to meet Arosha, I want to murder Arosha Disanayaka, where can I find him? Or Premali will not tell lies, so Premali will tell the truth. Arosha Disanayaka can be found at such and such address. You know, that's looking at the action. I mean, it's a crude example, but and then of course the net result might be I might be dead. You know, that's a very kind of rough example. But here we are looking at the action. That's deontology. And then of course utilitarianism is what the outcome, what the ultimate outcome. There was two major schools of thoughts were proposed by the great German philosopher Immanuel Kant is the one who said we must always do the right thing, or we must look at our action. Then of course there were two Scottish and English philosophers, Jeremy Bentham and John Stuart Mill, who proposed that no, it's not the action which matters, but the outcome. Now it is from those two that what we call patient-centeredness comes. Patient-centeredness is there is a patient in front of you and you do the best for your patient. But what at times the best for your patient may not be the best for the society. Simple example is, if there is, shall we say, a commercial sex worker who is with you who is HIV positive, and patient-centeredness, you will maintain confidential. She says, doctor, don't tell anyone. I can't stop my job also. I will carry on with my job. So, you do the right thing towards the patient, but the society will suffer as a result of that, because that patient might be a source of HIV for so many other people. So that's patient-centeredness that can be harmful at times to the society. Then, of course, society-centeredness, that is utilitarianism, when you look at the benefit for the society and not the individual, that may actually be harmful towards individuals. So roughly what happens is clinicians are very patient-centered. We are very duty-based. We are Kantian people. And of course, the public health people are very society-centered. They are fully utilitarian, and then they are with Bentham and Mill. Now, these theories are nice for people who have interest, but the medical community always had a problem converting these theories into actual principles which can guide practice. So now we have 4 principles. All of you know these 4 principles: autonomy, beneficence, non-maleficence, and justice. So when we have a problem, we don't have to go to classical ethical theories. We know how these principles, and we can apply to this. But interesting thing is, if you ask people, from where on earth these 4 principles come, those who even deliver lectures have no idea from where these came. They have no idea what, who said that these are the principles. Well, in 1979, 2 professors of medical ethics from the Kennedy Institute of Ethics in the USA, they wrote a book called Principles of Biomedical Ethics in 1979. And they crystallized the theories into 4 principles, these 4 principles. And then, of course, their books have been reprinted, edited. There is, even now, there is, I don't know, 12th edition or whatever of the book. I have a couple of editions earlier book. If anybody with interest, it's a good read. So this is the book from which all these principles came. So now you know. And then, of course, autonomy is a very very limited term. Some people actually talk about respect for persons there, and then go on to say autonomy refers not to informed consent, and it also covers truth-telling and confidentiality. The fact that you're retaining confidentiality and you always tell patients truth. So autonomy is not purely informed consent, but it can include things like truth-telling and confidentiality as well. Right. One slide on autonomy. You must know what valid informed consent is. Valid informed consent requires 3 criteria to be fulfilled. 1, the patient has to have capacity to give consent. Capacity means somebody who is maybe a minor. In Sri Lankan law, a minor is up to 18 years. Whether somebody less than 18, shall we say 16, can give valid consent has not been tested in a court of law, but I think it will be accepted, because you all know that legal age for marriage in Sri Lanka is 16. Is 16, is it? Or whatever. anyway, up to 18, Sri Lanka, it is considered minor by law. But if a court case comes one day, we will know from which point onwards the judges will accept that somebody has capacity to consent. That has not been tested so far in a court of law. Also, if somebody lacks mental capacity, like somebody with advanced dementia, somebody who's unconscious, so they don't have the capacity to consent. So, informed valid consent can only be obtained by those who have mental capacity to consent. Now, capacity will include being of the correct age, ability to receive information, ability to understand and evaluate information, and ability to decide. So all of these will be part of consent. Now, if a patient has advanced dementia, they will be able to receive information, but they will not be able to retain and evaluate the information and then decide on that. So that part is missing. So that's the capacity part. Second thing is, even if somebody has capacity, the patient has to be given all the correct information. All the relevant information has to be given, and that decision has to be made voluntarily without any kind of coercion or undue influence, which might include actually paying money for something. For instance, if I want to do a research project and I want valid informed consent, one is it has to be somebody with the correct capacity. They have to be given all the correct information, what harm can come to them, what benefit can come to them. They have to agree voluntarily. I can't take a group of prisoners and have the prison guard standing by and making them give consent. So that is not valid. Oh, I can't say I will give you 1,000 rupees if you agree to this. So that's not voluntariness. And wherever a patient lacks capacity, the general principle is the medical professional needs to take a decision with the best interests of the patient in mind. Now, this is the English law. This has not again been tested in Sri Lanka. There is no law in Sri Lanka to clearly that to state what is right or wrong. So what happens is, if it is challenged in a court of law, the judges will go to, if there is no law laid in Sri Lanka, if there is, they look at past court decisions, that those are called precedents, or they will mostly English law to look at cases in England and decide. So we are generally okay if we always act with the best interest of the patient in mind, because English law accepts that as the premise if the patient is unable to does not have the capacity to consent. Right. Now we spent a fair amount of time earlier about how to navigate the communication skill station, 7 steps. Now, here is how you are going to navigate through an ethics station. How do you resolve an ethical dilemma? So these are the steps you must go. One is identify underlying ethical issues. What are the problems here? Second thing is apply the principles to those problems. 4 principles: autonomy, beneficence, non-maleficence, and justice. I have not explained those. I'm sure you might know. If you want, I can spend 1 minute and explain that as well later. Then, of course, step 3 is weigh outcomes. Now, autonomy, I have already told you what autonomy is. Beneficence is what you do. Now, your relationship is with the person in front of you, is with the patient and not anybody else. So what you must do has to be beneficial to the patient. Non-maleficence is what you do must not be harmful to the patient. Now, if by any chance you want to treat somebody with severe sepsis with antibiotics, the benefit is giving antibiotics, but when you put a cannula, patient is going to feel pain. So on one hand, you have a duty for beneficence and non-maleficence. So you have to break non-maleficence because the patient has to undergo pain. But when you look at both those two, you know that the beneficence is far greater than the maleficence. So you will, without even thinking about it, put a cannula and give the IV antibiotics. So you weigh outcomes, that is apply principles and see, how do the principles apply to each situation. Now we look at a few scenarios, then you will understand this better. Then, of course, invariably, very often you will find conflicts between principles. The action that you do may have a beneficial effect, but may have a non-beneficial effect, like non-maleficence problem, maleficence problem also, like the cannula I told you. So very often you might find a conflict between beneficence and justice. For instance, a classic example is this ICU bed. You have a patient who is marginally unwell. You want to put the base. You have 2 patients to put to the ICU. There's only 1 ICU bed. So, how do you manage an ICU bed, giving it to the most deserving patient? So you have a beneficence duty towards both patients, but you will have to choose between them as to the one who deserves it most. So it's a justice issue. Justice is actually, if you look at the 4 principles, the first 3 principles, autonomy, beneficence, and non-maleficence, they are all to do with Kantian or deontological principles, your duty towards the patient. So that's one side. Justice is your duty towards the entire society, not just to the patient in front of you, but to all the patients who need that. So that is the utilitarianism, or the Bentham, Stuart Mill aspect of it. The utilitarian aspect comes in allocation of scarce resources. Now, as a doctor, you have all those. So beneficence versus justice is a classic example of deontology versus utilitarianism. That's why I explained it at that moment. Then, of course, very often we might have autonomy versus beneficence. Patient might say, I don't want this particular treatment, when you know very well as the doctor that the patient will benefit from that. What do? Or it can be autonomy versus justice. Patient might actually require, say, doctor, I would like to have this scan done very quickly. And then, there might be another patient who needs a scan, who has got admitted later, but who needs a scan more urgently. So, autonomy versus justice. Patients don't have a right to, by autonomy, you must remember that patients don't have a right to ask for inappropriate treatment. You can't have upper respiratory tract infection, go to hospital and ask for an ICU bed. But if it's an appropriate request, if they also will benefit from that, and then of course, you might have autonomy versus justice conflict. So there are lots of ethical conflicts. And then how do you resolve this? Resolve any conflicts, remembering our primary obligation is to the patient in front of us. I'm being very selfish here. Being a clinician, I always say our primary obligation is not to the society, but to the patient in front of us. And we need to do what's best for the patient in front of us. But having said that, it's not that easy. Now, out of the principles, now, for instance, we know that, if it's autonomy versus beneficence, patient will benefit from chemotherapy. Patient says, I don't want those treatments, doctor. I have heard that they are awful treatments. So autonomy versus beneficence. Both are for your patient. So when both are for your patient, how do you resolve that? Though all 4 principles are supposed to be equal, autonomy is generally considered the first among equals. Even among equals, autonomy is probably the first. That's not a rule, but that's the general belief. I have unashamedly borrowed that phrase from a book by Jeffrey Archer, the great English author. He wrote a book called First Among Equals. So I keep stealing that title from him. Autonomy is the first among equals. If you are in doubt, one of the safe things to do is to seek the opinion from an expert. I'm not an expert, but I once remember I had a call from Dr. Satyajit, who is now a consultant neurologist in England. I think it was Satyajit, who called me and said, I have this problem. Sir, what is your opinion? I really kind of, it was really surprising, but I realized what he was trying to do. He was just trying to get some expert help about a situation where he was in doubt. Then, of course, when you take one decision, you know that there might be some harm because you're trying to balance the dilemmas or the principles. So you do what's called damage limitation. If you can't give the first bed to your patient, you at least try to get the second bed for your patient. So, damage limitation. You try to reduce the amount of harm that might come about due to the decision that you made. Then, of course, at times, you need to negotiate and look for compromise solutions. For example, you all might know Now, I spoke to you about autonomy versus benefits and somebody refusing treatment. You might, it's not one way or the other. You could always say, you know, you look for halfway solutions. You negotiate and say, you know, can you at least take this treatment? If you don't like chemotherapy, can you at least sit for a radiotherapy session, though that may not be ideal, or can you agree to surgery, which may not be the best, but that may offer some benefit. So you negotiate and look for compromise solutions. It may not be the ideal solution, but some solution you try to come for that. And then, of course, final point is when you're sorting out an ethical dilemma thing, you must remember that law overrides all ethical considerations. So whatever that you feel is ethical, at the end of the day, if it is against the law, then you need to do what is legally provided, because otherwise you will end up in jail. A classic example I'll tell you, in Sri Lanka, there is no law where doctors can cover themselves on a DNA CPR, or on not DNA CPR, but shall we say disconnecting a ventilator. Somebody is ventilated. There is absolutely no law in Sri Lanka. It has not been tested so far in a court of law, so we don't have precedents. And then there was this discussion a couple of years ago. I was on the same panel along with Honorable Justice Yasantha Kodagoda, who is a Supreme Court judge now. He was at that time, I think he was the Solicitor General at the time that we had this symposium. And it was very clear. He said, you know, don't even think about disconnecting a ventilator, because if there is a court case, you may be found guilty of manslaughter. Manslaughter is just below willful murder. It is quite possible that a doctor who disconnects a ventilator, if it is challenged in court, a judge might hold that you are guilty of manslaughter and you might end up with maybe 10 years in jail or something like that. So remember, if there is no law, we must be very, very cautious about this. About DNA CPR decisions, again, there is no clear law. If your decision is challenged in a court of law, there is a possibility. I'm not saying it is going to happen, but there is a possibility that some judge, you know, who thinks differently might find you guilty of manslaughter. And that can be very, very difficult for you. So what we must do is to try to have proper legal provisions for these critical matters. But for the time being, one must be very careful about these decisions where there is no law. If there is a law, say, for instance, a classic example is, now at times you might feel that an abortion is ethical in a particular instance, but abortion is illegal in Sri Lanka. So that's that. You know, though it's ethical, we don't do that because we can end up in jail doing that. So this is how you resolve an ethical dilemma. For any of the senior registrars, for any exam that you go, these are the steps that you go through. Look at the scenario, identify the issues, apply the principles and say, when I apply these principles to these issues, this is what I get. I have conflicting, you know, principles. When I put everything together, this I think takes precedence. Maybe autonomy takes precedence. And this is what I would do, but I won't stop there. I'll do everything possible to minimize the damage or limit the damage. I will negotiate with all parties to come up with a compromise solution. And I will also, if I'm not in doubt, I might ask an expert in ethics committee. In Sri Lanka, we don't have clinical ethics committees, unfortunately. We have only research ethics committees. But there are people who are interested in ethics, so you could have a chat with them. And then, of course, I will also check what the legal status is in this matter and make sure that what I'm proposing is within legal terms of this country. Okay? Right. Okay. Now, to summarize all these things, I'll take you through a few scenarios. Priyamali, what is the time? Have I gone over time already?
It's almost 1 hour gone. But we will discuss, that is fine. Like I think probably 10, 20, 15 minutes we can do this.
Sure. Okay. We'll look at this because I didn't want to rush through because I just want to train you all how to do now the scenarios. Scenario 1 involves research ethics. Now every single doctor must know about the Tuskegee syphilis study. Very briefly, it was a study which was carried from 1932 to 1974. conducted by, mind you, the Public Health Service and the Center for Disease Control in USA, two of the top government institutions in USA. There was a study which started in 1932 on the natural history of untreated syphilis in African American patients. Black Americans, what happens to them untreated syphilis. Patients were never told that, that they were, what was being tested. They were told to live normally, so the Black community, they would have lived normally in the community. They would not be told that this is a sexually transmitted disease that they're having. They will have sex with other people. So the researchers want to see, when they have sex with other people, how many people actually get syphilis, etc. And importantly, even after effective treatment, which is penicillin, even after penicillin was identified as effective treatment for syphilis, subjects were not given treatment because they wanted to make sure that, they wanted to follow them up till they died to see whether they died of tertiary syphilis or whether they died of something else. What were the complications of tertiary syphilis that they died. The researchers wanted to see. Then, of course, several people along the way protested against this, but these important public health institutions, they didn't take notice because, the Black Americans, nobody cared. Till, of course, one of the doctors, in desperation, like happens in Sri Lanka, he went to a newspaper and the newspaper broke the story. All hell broke loose after that. At that time, Ted Kennedy, John F. Kennedy's brother, was the Attorney General, I think. And then, of course, he started an inquiry. And it resulted, everybody understood what a bad thing has happened. There was something, a big inquiry, and something called the Belmont Report came. That's the first time some principles came out of all the ethical theories. First time somebody laid down principles. They laid down 3 principles. Respect for people, beneficence, and justice. With regard to research ethics, they laid those principles. Belmont Report, and in 1997, President Bill Clinton issued a formal national apology on behalf of the nation of America to all the participants. And I think, as usual, America gave $1 million or something for each family. But at least there was a formal apology from the president. Now, mind you, this happened in the USA. So this is how bad things can be. If we look at, I'm not going to ask you all to look at the issues which arise here. Obviously, informed consent or autonomy has been utterly violated. Beneficence has been utterly violated. Patients were not given treatment. Non-maleficence was utterly violated. Somebody could say, yeah, it's good because, white Americans can know what will happen if they don't take treatment for syphilis, so that, they will be advised to take treatment in the future. So that's why it's wrong with justice. That's what's wrong with utilitarianism, because when we go for society's benefit, we can actually harm individual people. So that's why we are always suspicious of this ethical principle called justice. Though we have to live with it, we must be very mindful of justice-based justification. Second scenario, again, I'm not going to ask you all to respond because we don't have much time, but this is again straight from the ward. I will read this. 69-year-old previously healthy patient was admitted following a TIA, developed a stroke while in the ward. She showed evidence of an ongoing evolving infarction, thrombolized after explaining risk to the son who was with the patient. Infarcted area turned hemorrhagic, patient's weakness increased, never regained full consciousness, developed aspiration pneumonia, discharged home after treatment of pneumonia in a state where the patient was confined to bed. The medical team told the truth that it was the medicine which led to the bleeding complication, and it probably made things worse for the patient. Family was unhappy, but said that they can't do anything because they agreed and signed. So this is one of the ethical issues you can identify here. Think about these things. Think about these things. Now, how about, what about beneficence? Yes, when we initially made the decision to thrombolize the patient, we had research evidence to say that the patient would benefit. So I think it was a correct decision. We did discuss with the family, but you must remember, families consist of many children, and one son might agree. Desperation depends on the information that you give. Also, somebody may have said your father will get up and walk once this injection is given, we don't know what was said. But other members in the family were unhappy. So in terms of beneficence, autonomy, I think, the team was justified. But unfortunately, an unexpected complication came, but it was the ethically correct decision. And then, of course, a very difficult decision came out, the duty of candor to tell the patient, actually the patient worsened because of the injection that we gave. And that is a very difficult thing, but we, even in the middle of a lot of difficulty, we actually told the family, and the family was obviously not happy, but we went ahead and told them that this is what we think. Unfortunately, this happens rarely, but it happened. Then, of course, you come to the question, should you not have told the truth about the complication? If we had not told the truth, we may have been being unethical because we were not truthful under autonomy. But of course, the family would have been quite happy with the medical care that they received from us. Family would have been happy about the medical care. They would have thought, and maybe the patient also would have been better. We don't know. The patient may have been better or worse. But we stuck to the duty of candor and we told them truth because we believed that was the right thing. If the patient was not told the truth, somebody could argue and say, their minds should have been at rest and they would have been happier. But having said that, when you look at the patient in front of you, you look at the 4 principles and you take what you think is the most correct decision, most ethical decision, because some of the consequences we can't predict. And we feel that we took the correct decision, though there were conflicts in terms of, we are not going to harm the patient, but a rare side effect came and we harmed the patient. So we breached non-maleficence unintentionally. And we tried to create beneficence, which didn't work out. And of course, autonomy, patient didn't have capacity to consent, but we took the decision after discussing with the family. Third scenario, again, something from the ward, 72-year-old patient with hypertension was admitted to the ward with shortness of breath. Creatinine was 6. The diagnosis is heart failure secondary to fluid retention. Doctors feel that he needs dialysis urgently. Patient refuses, saying he does not think that dialysis is going to help. He feels better with injections and wants to go home. He says, I had a couple of injections. I can breathe a little better. You see that the patient is really short of breath and that he wants to go home. So ethical issues that we identify, one is, of course, if we send the patient home, it will cause harm to the patient. So we are breaking non-maleficence. We are trying to do good to the patient by dialyzing. Patient will be that much better. We have a duty of beneficence, but it's patient's autonomy. So what do you do here? You will have no choice, but we can't retain patients against their will. We will have to bow down to their autonomous right to go home, but we will send them home. This is where I said that we need to go for damage limitation and compromise solutions. So we tried those compromise solutions and damage control. So we offered him the opinion, we offered to get the nephrologist into the ward, speak to him and tell him about the illness, because he just doesn't believe that he has a serious kidney problem. So the patient, so that was the compromise that we tried to offer him. Patient is in a hospital. Then he said, I have heard of a kidney doctor in Colombo, and he would like to go to Colombo and meet this kidney doctor and get his opinion. We know that it is perilous to send him to Colombo in that stage. And he said, I'll come back if the Colombo nephrologist says that the dialysis is needed. Again, ethical issues are patient's autonomy versus we know that sending him to Colombo is going to cause harm, may cause harm, non-maleficence. And of course, beneficence is also being violated. So what did we do? We kind of, we got him to take an appointment with the Colombo nephrologist at 4 o'clock or whatever. We informed the nephrologist that this patient would be coming to Colombo to see the Colombo patient. And then, of course, we gave a furosemide injection a couple of hours before and sent the family, with the family, sent the patient to Colombo to see the nephrologist. So, we know that it's not ideal. It's, Colombo nephrologist is going to say the same thing. We know that, but we respected the patient's autonomy, but we managed to come up with a compromise solution and reduce damage. So that's what I want you all to mention in exams as well. That is, the thing that we need to do at ward level as well. One clinical scenario based on justice. Now, in the height of the COVID epidemic, pre-vaccine area, everybody who tested positive, whether they liked it or not, was sent to mandatory quarantine. We know that patients, you remember that scene where in, I think, Valisara or someplace, some drug addicts were, dragged from trees by the Navy and then put into buses and sent to quarantine center. And the Navy itself had an outbreak of COVID at that time. And also all those mask mandates, where we were unhappy with anybody who was not wearing. Wilson Karu, the actor, was arrested by the police for not wearing a mask in a queue to collect the 5,000 rupees. So that's all justice. For the benefit of the society, individual be forced to do things against their will. Now, though I am generally against justice and I'm all kind of a Kantian person, all for autonomy, beneficence, non-maleficence, I confess at that time I was happy that everybody was being forced to wear masks, because I felt that that is the way to protect the society, and individuals' rights had to be compromised at that time. So, we have our principles, and at times we are flexible with our own principles. But I want to highlight that and say, that is one instance where all of us, I think just about everyone, but all of us gave about all this patient autonomy. We kicked it aside, then went agreed with the justice phenomenon, right? Okay. And I think this is the final scenario. Now, again, these are all real life scenarios, things which happened to me the past couple of days. So I want you all to be aware of when you're doing ward rounds, when you're teaching, when you're learning, please be aware of all these dilemmas which you have to face. These things are part of your everyday life. So when I was preparing for the lecture, I just thought about what I had seen over the past, heard over the past couple of days. And everybody, all of you will have the same things that I'm facing. A patient with a past history of ulcerative colitis is seen by the gastroenterologist with a complaint of lack of energy and feeling unwell. Previously, under a GI surgeon, a patient had been under a GI surgeon who had treated ulcerative colitis for a few years and stopped treatment, saying ulcerative colitis was cured. The gastroenterologist does a colonoscopy and detects ongoing ulcerative colitis with a possible malignant polyp in the colon. Now, what does under the professional etiquette? Now, this is not real medical ethics as such. Medical ethics is to do with doctors and other medical professionals dealing with patients. That's medical ethics. This is more professional ethics or professional etiquette. Does he mention that the previous doctor's decision to stop treatment was incorrect? Well, we don't usually do that. We just stick to what we have to do. Okay, the gastroenterologist is a nice guy. He just looked at all the reports and the colonoscopy, and then he said, you have this illness, and then you take this treatment and go on. So we try in the professional etiquette not to criticize our colleagues. Of course, people do criticize colleagues for different purposes, but we should try our level best never to criticize professional colleagues. Stick to what you are supposed to do. Don't comment on other people. Look at the patient in front of you. Do what needs to be done. The complication arises. What if the patient says, previous doctor said ulcerative colitis was cured. Now you say it's still on. Did the previous doctor get it wrong? Now, that is a tricky one, because here you have to say something. You need to make a commitment. Do you kind of, shape up the professional colleague, or do you tell the patient the truth? In this instance, you must always remember your primary ethical duties towards the patient. And if the patient asks a question, you must give a truthful answer. And even if it has to come at the expense of the reputation of a professional colleague, you need to tell the patient, yes, I think that decision was probably wrong. But then, of course, you must be very fair to your colleague and say, I am making that judgment in hindsight. I am now seeing you having this illness, so it's easy for me to comment on that. But at that time, I don't know, because I didn't see what he saw. He may have had his own reasons for stopping, but all I can tell you is now you have this illness, and it is possible that had you continued the treatment, that this situation may not have arisen here. So you must remember that your duties towards the patient, always to the patient. You must be truthful to the patient, but you must be reasonable and fair to your colleague, because at the end of the day, our community has to go on. I'm not suggesting that you lie to patients to shape up your colleagues. I'm not suggesting that at all, but be fair and mindful about your colleague as well, because there is a beautiful saying from Greek philosophy which says, what is good for the hive is good for the bee. You know, what is good for the there is good for the masa kind of thing. So what is good for the profession will be good for us individually as well. So we must get out of the practice of harming colleagues with narrow objectives in mind. It may be professional jealousy, it might be increasing private practice, I don't know. But we must be fair to our professional colleagues as well. Right, the final slide. There are a few important documents I would like you all to think about and look up if you all have time, if you have any interest in ethics. There's the Nuremberg Code. Nuremberg is a town in Germany where the trial of the Nazis, German Nazis, was held around about 1946-47 when the Second World War was over. And there were many doctors also on trial for carrying out unethical research on detainees in Nazi concentration camps like Auschwitz. You know, they did a lot of research and then actually found some very useful medical information also, but in terrible ways. For instance, most of the knowledge that we have on management of hypothermia comes from those concentration camp trials, research. You know, they used to just take the prisoners and dump them in freezing cold water, keep them, and then keep them for hours and see, you know, whether they would die, how long they can survive, and then take them out and try different ways of rewarming them to see which would be better. And one of the ways of rewarming was they used to dump them in boiling water and see, you know, what will happen to the patient. So some of those findings have a lot of medical validity, but they were obtained with heinous methods. So Nuremberg Code came out after the trials about how to conduct research without harming human beings. Then there's something called the Helsinki Declaration, which came from the World Medical Association in 1964, again looking at recent research ethics. Now there is the 7th amendment to the Helsinki Declaration. There is, I think it came about 2013, the last amendment came, so that document is also there. So anybody who has an interest in research ethics should look at those. Then there's the Belmont report, which I referred to earlier, which came from as an offshoot of the Tuskegee research debacle that lays down 3 principles: autonomy, beneficence, and justice, but in terms of research projects. Then, of course, this wonderful book of Principle of Biomedical Ethics, which really crystallized the 4 principles for use even by clinicians like you and I, researchers and clinicians, everybody. The 4 principles came from this book. That is also a wonderful book. It's still being published by editions. I believe both these professors are still alive, and that's great. So that's another important document. Then I think, in my personal opinion, the best journal, if you want to look up, is the Journal of Medical Ethics, which is a BMJ journal, which is a wonderful journal. I personally subscribe to that as well. That discusses very current topics, which is of interest to you all. There was a brilliant debate a couple of years ago on whether commercial sale of kidneys should be permitted or not. You know, that's something which is very topical here. The ethics of it, there was a debate and both sides had strong arguments. Then, of course, the last article doesn't rank alongside the other ones. But for anybody interested, looking at what professionalism is, what medical ethics is, and what good medical practice is, how do they complement each other, how do they differ from each other, I, along with Dr. Professor Harshini Rajapaksa and Dr. Mihiran, wrote an article and published in the first edition of the Asian Journal of Internal Medicine in 2022. That article is in public domain. It may be worthwhile for somebody to read and just have a look. Right. one final sentence I want to tell you is I've spent a lot of time telling you how to pass the communication skills and how to pass the ethical scenario at maybe MBBS, maybe MD, maybe MRCP. But what I want to tell you is have no gap between your clinical practice and what you do in exams. Your training for exams should be the training for clinical practice. What you are doing in the exam should be what you do in the ward. There is no difference. You must not do these things for exams and forget about it and do other things in the wards. So minimize, have no gap between the communication skills and ethical practice in your clinical practice and what you do in exam. So that's my final plea. Premali, I truly apologize if I took too much time. I thought I discussed only what was relevant. If there's anybody has any question, I'll be happy to answer that. I hope this has been a useful exercise.
If you have seen this, like there were 120 participants, 105 are still waiting.
All right,
And
okay.
there are three Q&A. You can see that Q&A. Shall I read it? Then
Yes,
you can
please, if you
answer.
can.
Yeah.
Yes, please.
Good evening, sir. How many concerns we have to ask? Just one, so keep on asking till they say no more concerns. Thank you.
Good question. And Premali, I think you can also help me answer. We usually teach 2 concerns to the 1 or 2 concerns maximum to the surrogate, because we are dealing with a 10-minute or 20 minutes communication skills scenario. We don't have endless concerns. So if you address about 2 concerns, that should be fine. Premali, you agree?
Yes, yeah.
Not really more than 2. We can't. We don't have time for that. But in the ward, yes, all concerns. In the ward, all concerns. Okay. Second question.
Sir, how to approach to an angry patient or a relation, especially in exam purpose?
Okay, right. I forgot actually to write that as possible scenario. We don't usually do that because surrogate has to be a very good actor to become angry, but we can do that. So when they are angry, they are usually angry about a mistake. The principles are you acknowledge that there is a mistake, number 1, and you acknowledge that there is a mistake, number 1. And you apologize saying, we are sorry about this. We are sorry, not I am sorry, but we are sorry because you work as a team. We are sorry about this. That's second principle. Third principle, what you don't do is fix the blame on somebody. You say, no, it was not me, but it was a microbiologist who suggested the wrong antibiotic or something like that. You don't fix the blame on anyone. You take it as a team. So you say, acknowledge that there has been a mistake. You apologize profusely, and surrogates have been trained, after you apologize about twice to calm down. And third thing is you say that you will try to obtain an appointment with a senior colleague, maybe the consultant, to discuss any further matters. That's number 3. And number 4, you can say that you have already had a discussion within the team, or you're going to have a discussion in the team, which is going to look at ways not for this to happen again. Right? So those are the 4 things. 1 is you acknowledge that there has been a mistake. Yes, there has been a mistake. 2, I am sorry about, not I am, but we are sorry about the pain that has been caused to you, the discomfort that has been caused to you. We are really sorry about that. And third thing is I will try to get an opportunity, if you wish to speak to somebody senior than me, maybe the consultant, to get any further details that you want. Number 4, we have already had a meeting, or we are going to have a meeting to come up with a mechanism to ensure that this mistake is not repeated again. So those are the 4 principles that you do. What you don't do is fix the blame on something to say, no, it was the senior registrar who did it, or it was the consultant who told me, so I did it. No, you don't fix blame on anyone. Okay, Premali, if you want to add something to that, I'll be happy.
No, that is it, I think. And there are 2 people actually. Thank you. Like one said, it was very important, interesting presentation. I believe that most of us need to learn a lot more on this topic. Thank you, sir. There's somebody from MO Psychiatry from Vaunia, who has written her name also. Thank you very much, sir. It was very informative. Those are the questions.
Okay.
And I think it's almost spend 1 hour and 30 minutes. So I think because they have enough chances to write the chat box and all, we have answered the questions.
Yeah, I mean, they are free to contact me. I mean, you know,
Yeah.
at any time that if you want. I mean,
Yes. And just to tell Professor Arosha, you fulfill my task like in distinction, like you have told, like it was a fascinating talk, and you did like in the way which I want, actually explain about this exam scenario which everyone is interested. Then you come back to the bedside, actually how we practice. That was really fascinating, and I also learned a lot, and it was really interesting talk. You know, usual ethics are very boring, but this is very interesting. It's no one will believe there's 120 people waiting for this whole this UB. This is the highest attendees for the SR forum.
thank you very much. I'm happy that
Yeah,
if
thank you
people
very
felt that.
much for your time and your knowledge and everything. And I have few people to thank. Mr. Dishan Fernando, always helping us and giving this platform and our IT facilities, and Gets Pharma for sponsoring this, and Sri Lanka College of Internal Medicine President and the Council for permitting this. Thank you very much. Have a very good night. Thank you very much, Dr. Arosha again.
Thank you so much. Take care. Take care. Good night to all of you. Take good care of yourself. Okay, bye.